Keep on trucking for this hour 3. I love it, right? Oh, you guys we're a little early. That's okay. Okay, so next up we're looking at circulation and EKG. So who knows a lot about EKGs in the class? Okay, so if I say something dumb, correct me, okay? We're going real basic though, so I think I'm pretty good understanding of this part. But you know, I'm not going to be able to differentiate, you know, a left bundle branch block from, you know, but I can tell if they're in VTAC. I can tell that if they're dead. You know, I can usually tell. But at least to get you guys a basic understanding of what's going on here. So we're going to talk about membrane physiology and action potentials. Who's excited about action potentials? Yeah. All right. All right. We're going to talk about that, and then we'll look at cardiac function and vascular regulatory systems. All right. So first off, we'll look at the cardiac cycle. A little bit about this previously. We already know how blood kind of flows through the major chambers here within the heart, where they're going to be the blood actually coming into the heart, where it's going to be leaving from. Let's talk a little bit more about in detail about the actual process of systole and diastole. So again, no blood coming in through superior and inferior vena cava. Blood's going to be flowing through the atria to the ventricles and leaving out to the lungs, coming back in through the pulmonary veins to the right atria, right ventricle, and out to the aorta. Okay, that's the general flow, but how does the actual pumping occur to allow that to happen? All right, so the cardiac cycle, refer to this as just being that repeating pattern of contraction and relaxation of the heart. Systole is going to be, how would you describe systole? Yeah, contraction essentially, right? So systole is going to be that contraction of the heart muscles. Systole is, when we're talking about this, you can break it down into ventricular systole, and then we'll also look at atrial systole as well. Okay, so again, ventricular just referring back to the ventricles, atrial just talking about the atria. Then we'll look at diastole, which would, how would you describe that? Relaxation, right? So I'll have diastole will be the relaxation of the heart muscles. Again, you can still break that down into ventricular diastole and then atrial diastole as well. Some other terms we'll look at is going to be the end-systolic volume. This is essentially going to be the amount of blood that's left in the heart after the ventricle has contracted. Okay, so again, if you have increased residuals there, that can be problematic, right? So for instance, if you have a high end-diastolic volume, that's usually indicative of you didn't have enough pressure to force all that blood out through the ventricles, or maybe the muscle's not really up to snuff. And so we'll look at things that can cause end-diastolic volume issues, or end-systolic volume issues. End-diastolic volume issues are going to be that total volume of blood in the ventricles at the end of diastole. So how much blood is available to be pumped out of the heart. Okay, so you guys think of anything that would cause there to be low end-diastolic volumes? In diastolic, this is going to be more of an issue of if the chamber itself is, specifically the left ventricle, if you would have hypertrophy of that left ventricle, right? So if you chronically are kind of overworking the heart, that muscle likes to hypertrophy just like any other muscle, and you can run into issues where, one, it can be more stiff and doesn't like to relax very well, and if it can't relax very well, then it can't really fill up with as much blood. That can be one of the big problems that you run into, and so that can lead to things like CHF, lead to some other problems that can happen, kind of chronic hypertension or chronic afterload issues. So we'll get more in detail on that, but just realize that there is a difference between in systolic volume and diastolic volume, and they can, high values or low values of either of those can be indicative of different problems. Okay, so essentially the cardiac cycle, as we can see here, we're going to have venous return to the right atrium. That's going to allow for our venous flow is going to arrive eventually into the right ventricles. Once that ventricular systole occurs, it's going to force the blood in through the pulmonic valves, then it's going to go through the pulmonary arteries, and then lead to the where it can be oxygenated out in the lungs. It's eventually going to come back in through the pulmonary veins into the right atria. Now we have oxygenated blood. It's going to be returning it back to eventually we're going to have the oxygenated blood arriving back into the right, left ventricle. That left ventricle will then contract with ventricular systole, and that's going to lead that blood to head out through the aorta, and now we have the cardiac cycle essentially, and everything can start over again. Obviously, the venous and the arterial side are going to be happening kind of at the same time. It's not like you like pump the blood all the way through once and then you're done. So everything's kind of happening synchronously there. So looking at the time frame here, you can see where the atria will contract. This would be considered atrial systole or diastole? That'd be systole, right? Which will then be followed by the ventricles contracting, right? We don't want these to happen at the same time because always that would lead to some problem pumping, right? So we need to make sure that things are working appropriately. We'll see with the electrical system how that works, how we prevent the things like the atria and the ventricles contracting at the same time. But again, when the ventricles are contracting, the atria should be relaxed at this point. Again, that would be considered systole or ventricular systole occurring, and then we have that diastole. Notice you probably spend more time in diastole than you do in systole, which kind of makes sense. You don't want your heart to be constantly contracted. That would be problematic. And again, when you have that diastole, this is when you have the ventricles starting to relax and fill, and then the final bit of blood that's going to be coming back from the ventricles and be happening when that atria contract. Okay, you notice a pretty short period of time here, like 0.8 seconds for a heartbeat. This would probably be around like 70 beats per minute or so. Obviously, this can speed up and slow down depending on certain influences, which we will see what those are in just a few minutes. So again, during this ventricular systole, we'll just consider this to be kind of the overall systole that occurs here because this is the main thing pumping blood out into the systemic circulation. You're going to find that the atria are going to be relaxed. This will be atrial diastole. And again, when the ventricles contract, that's going to close those AV valves, and that's going to be our first heart sound. This will be S1, that lub sound that occurs there. And so there's going to be a period of time where the ventricles are contracting to where both set of valves are closed. Okay. As that pressure is building, we call that isovolumic contraction that's happening there, because again, the volume of blood is not really changing in the ventricle. We're just kind of squeezing to build up pressure, and then once that pressure is high enough, it's able to open up those semilunar valves, push it through the aorta, and then we're going to have blood flow occur there. Okay, so again, the blood is going to go to the lungs and the body via the pulmonary arteries and the aorta when that process is happening there. But again, there will be that isovolumic contraction that happens, and we'll see with the diastole, there's also an isovolumic relaxation that occurs as well. I'll show you some graphs and what that looks like in just a second. Yeah, so basically when you see when the ventricles contract, right, they're starting to squeeze down, the first valves that close are going to be what? It's going to be the AV valves, right? So those are going to close down to prevent that efflux of blood back into the atria. At that point, the semilunar valves are still closed, okay? All right, so because those are closed in order to prevent blood from the aorta and from the lungs flowing back into the ventricles. So at that period, there's two valves closed at the same time, right? And that as the ventricle's squeezing, that pressure is building, and as soon as that pressure is high enough in the ventricles, it opens up the semilunar valves and allows blood to flow out. Okay, so there's a period of time where things are both valves are closed, and you need that pressure to build in order for the one to open, the semilunar valves. It'll make it better since we're looking at the graph kind of at the same time. I'll show you this one in a little bit bigger detail when we get there. Again, when during systole, the ventricles begin to contract, the pressure is rising. Again, those AV valves close, which is that initial lub, and then you have the isovolumic contraction as you're allowing that pressure to build up before the semilunar valves open. Once those open, the blood is then ejected into the pulmonary arteries and into the aorta from the right and left sides, respectively. Obviously, we have to have the ventricles relax at some point, so then there's ventricular diastole, and so the ventricles can relax. This is where you're going to get the semilunar valves that are closing, so that's your S2 sound, right? This is your dub. As that pressure differential, the pressure is higher in the aorta and in the pulmonary arteries. The pressure is higher there, so that closes those valves as the ventricles start to relax. You're going to have this period of isovolumic relaxation that occurs as well, because again, both valves are going to be closed, and then as that relaxation happens, the chordae tendineae and those papillary muscles relax. That allows that mitral valve and the tricuspid valve to open up, and then you allow blood flow to come from the atria down into the ventricles. So initially, when you have the AV valves open up, blood's going to be flowing from the atrium into the ventricles, mainly by gravity. So most of the blood actually gets into the ventricles just by pure gravity alone. But then for that last final squeeze, that last bit of blood, that's when you're going to have atrial systole. Okay, so atrial systole will occur. It's going to push the rest of the blood into the ventricles and then get ready for another ventricular contraction. Make sense so far? All right. Yes, sir.
So when the papillary muscles and the chordae tendineae they contract, the valve open?
No, when those, that's a good question. So when the papillary muscles and the chordae tendineae for like the tricuspid and the mitral valve, when those tighten up, that happens during the ventricular contraction. They do that in order to prevent the valve from everting, okay. Right? But when you have that ventricular diastole, those actually relax and they allow for the valve to open up. Good question. Okay. So again, during diastole, pressure in the ventricles is going to fall. The semilunar valves end up closing because now the pressure in the pulmonary arteries and also in the aorta is higher than it is in the ventricles. And now you have that isovolumic relaxation happening there. pressure in the ventricles fall even lower still, and then below that are the atria. And now that the pressure in the atria is higher, that's going to allow for the AV valves to open up. And again, the blood flows via gravity. The ventricles are going to fill up now. The atria then contract. And that atrial systole, that sends out the rest of the blood, getting ready for another ventricular contraction. Okay. We'll show you this graph in a little bit bigger detail in just a minute. Take this minute. So essentially, we can look here at this graph and see several different things going on. So it's a little busy at first, but we'll kind of look at it piece by piece. Notice here we're going to have pressure, and then we're going to have volume here on both top and bottom of this graph here. And then you can see kind of time as we go forward. And so you can see what the EKG strip would look like. I'm sorry, this is the heart sounds. You can see what the EKG strip looks like on this one, EKG right here. You can see what the heart sounds are doing, and then you can look to see what the ventricular volume and atrial volume are doing. We can see what the aortic and the atrial pressure are doing as well. Atrial and ventricular pressure. So again, which one do you think is going to be a kind of higher pressure type of system, the ventricles or the atria? Yeah, the ventricles, right? Because they're going to have a lot more pressure to overcome when you're looking at the aorta, the pulmonary arteries there. So again, when you're looking at initial ventricular contraction, you're looking at ventricular systole. You can notice here that you notice that the AV valves are closing as that occurs. Notice here this red line is going to be that ventricular pressure that's going to start to build. There's the aortic valve that is going to open at this point, but during this sliver of time here, what do we call that? That's the isovolumic contraction. So notice there's no change in volume. You can see this blue line is the ventricular volume. There's no change in volume here at this time point, but just the pressure is rising pretty significantly. Once that occurs, you're going to have the aortic valve that's going to open. That allows for ejection of blood out, and then the pressure starts to relax now. As that pressure drops, the aortic valve is going to close at that point and allow for that isovolumic relaxation to happen. So the pressure drops, but notice how the blood volume is staying the same here. And then once the pressure in the ventricles is below that of the atria, now the AV valve opens up, that mitral valve opens up, and allows the blood to flow in at this point. Okay? So if you were to compare this with an EKG, and we'll talk more about these details, what's happening here, but that QRS wave, this big wave here, is going to be that ventricular depolarization, and then during this diastole period, you're going to have that repolarization of the ventricles that happens. This is your T wave that happens at this point. As our heart sounds are happening here, the initial S1 happens when those AV valves are closing during initial ventricular contraction. Then you're going to have the dub sound as you're having the relaxation as the semilunar valves close. Everyone with me so far? Just work through it a few times. It's a busy graph, I'll admit, but I think once you kind of get a good feel for how the actual cardiac cycle is working, it'll make a lot more sense when you kind of get into it. You want me to go over that again? You want me to go over it again? Okay, I'll go over it again. Okay, so again, looking at just an initial cardiac cycle. Again, this red line here is going to be looking at our ventricular pressure. You notice how the atrial pressure stays pretty low for the most part. Like, it's not going to ever equal that of the ventricle, which is probably a good thing. We don't need it to have that high pressure, because really all it's doing is pumping blood into the ventricles. But initially, when you have ventricular systole, so the ventricle is contracting, this is going to lead to, as that pressure in the ventricle rises, it's going to close those AV valves, right? So that's going to be S1 or S2? S1, right? S1 is going to be the lub, that's your AV valves closing as you have the ventricular contraction. Because now the ventricle pressure, notice here, is much higher than the atria, and that's what causes the mitral valve to close at that point, okay? So once that occurs, once the AV valve is closed, your aortic valve is still closed also. So now you have a fixed amount of volume in the ventricle. The pressure is rising as you contract that muscle, and eventually you're going to have the AV valve open up. So you can see here the aortic valve opens. This is going to, I'm sorry, the aortic valve is opening here at this point. This is where we're going to have ejection of blood. So you notice how the blood volume is going to drop pretty significantly. Notice how the aortic pressure is going to be the highest at this point as well, because now all this blood is kind of flowing into it. As the ventricular pressure drops, that's when you're going to have the aortic valve close at that point. That's going to be your S2, correct? And then before the AV valve opens up, this is where we're going to have the isovolumic relaxation occurring there, right? So the volume of the blood, and they're staying the same, but the ventricle is still relaxing. Once that relaxes enough and the pressure is low enough in the ventricle, the atria are going to open up, the AV valve opens up and allow blood to flow through via gravity. Then you can have atrial contractions that can occur. So again, that's going to be that P wave when you have the atria contract, and that allows that last bit of blood to flow into the ventricles and then get ready for another contraction.
How is volume still lowering even though the aortic valve is closed?
Right. So looking at the volume here, so again we have our, this is where the ventricular volume is dropping, at this point.
Oh, okay.
Yeah, so it's kind of the lowest it's going to get there. Yeah. With me. Okay, so go over it a few times. Just listen to the video a few times, and then it'll make more sense as we go forward. And we're going to talk about each of these kind of steps in more detail, and it makes a lot of sense when we get to like the EKG and all of that, and you see how the actual electrical system of the heart is working specifically. Anyway. Okay, so looking at electrical activity of the heart, what's actually kicking off all these contractions to occur? What's actually happening here to lead us to have controlled this functional syncytium we'll talk about, what allows for that to actually occur. So look at electrical activity and how that kind of has a role to play with the electrocardiogram, the EKG. So looking at electrical activity of the heart, we're going to see that one of the big cranial nerves that is involved here is going to be the vagus nerve, or nerve 10. And this is going to be coming from the medulla. This is going to be controlling both the sinoatrial node and the AV node, or the atrioventricular node. Okay, these nodes are really important because what's another name for these type of nodes? These are pacemakers, right? So these are going to be the things that actually dictate how fast the heart's going to be beating based on several influences, which we're going to look at. Basically, looking here, see the SA node is going to reside on the top of the right ventricle, the right atria, and you're going to see the AV node is kind of sitting here, right between the border between the atria and the ventricle. Notice how things are kind of aimed in this kind of direction here. As you can kind of think about it on yourself, you can see it kind of aimed in that direction. This will be important when we're talking about EKGs and how those vectors are going to look. We'll get that in a few minutes. But anyway, once you have the initial SA node is going to be the primary pacemaker. In a lot of cases, this is going to have the fastest rate is going to be involved here. That's going to send a signal down as it causes depolarization, causes the AV node to depolarize. And notice here that there's not a lot of electrical flow between these parts here. There's a fibrous tissue that actually prevents the atria contracting from kind of depolarizing the whole heart. We want that to occur because otherwise, if we had the atria and the ventricles contracting at the same time, we wouldn't have very good flow. So you need that fibrous bit of tissue between here to make sure that the ventricles contract after the atria do. Anyway, so you have this basically your bundle branches. You're going to have your Purkinje fibers reside, and notice how it's going to go down through the heart, and it's going to cause these branches to come out here. Okay, we'll talk more about those in detail. But that allows for causing basically the squeeze of the ventricles to occur from the bottom up, right? So causing from the apex of the heart up to the base of the heart. When we talk about that, so this is considered the apex of the heart. This is going to be the base of the heart when we talk about directions. Okay? So this allows for squeeze of the heart to happen from the ventricles from the bottom up, and that allows for that good flow of blood out of the ventricles or out of the aorta, out into the pulmonary arteries. So we mentioned that the vagus nerve is important for innervating both the SA node and the AV node. Do you guys know what neurotransmitter the vagus nerve is going to be releasing? Acetylcholine, yeah. So acetylcholine is going to be released from there, and basically you can see acetylcholine coming out from here. It's going to be releasing onto the SA node and the AV node, and this is going to have a direct effect. Actually, I'm sorry, this blue line here is going to be the vagus nerve. This is going to have a direct effect on changing the rate of heart contractions, right? So this will cause it to either speed up or slow down based on the amount of acetylcholine we're releasing. You guys know the receptors this is going to be hitting? So with acetylcholine receptors, you either have nicotinic or you have muscarinic. Muscarinic, yeah. So it's actually muscarinic receptors. They're going to get hit here, and it's going to change the speed of the heart. We'll talk about why that occurs in just a few minutes. The other big thing, and again, the vagus nerve is part of the sympathetic or parasympathetic nervous system. It's parasympathetic nervous system. On the other hand, you're going to have the sympathetic nervous system. And what does the sympathetic nervous system like to release? Norepi, epinephrine. Right? So this is going to be released from the sympathetic nervous system, and not only will that innervate the SA node, the AV node, but it's also going to have direct innervation here of the ventricles as well. So you're going to find that the cranial nerve 10, the vagus nerve, has a lot of effect on just heart rate, but you're going to notice that the sympathetic nervous system has a lot more to do with contraction and also rate as well. Okay, so look at the kind of balance between those two. So I mentioned that this pacemaker potential. So pacemaker cells are going to be within the SA node, also the AV node, but primarily the SA node is the thing that's going to be setting up our primary heart rate for the most part, because that's the one that's beating the fastest, is going to be sending the strongest signal for the most part. Now, can people survive without an SA node? Yeah, so what takes over at that point? Yeah, then the AV node actually ends up taking over, and that can be your primary pacemaker for some of those patients. What if you had no AV node? You still have the Purkinje fibers and things like that that can still actually lead to a contraction. But you'll notice that the heart rate will actually go down pretty precipitously as you start to lose those pacemaker cells, right? So for instance, a normal heart rate would be, rest would be like what? Yeah, like say like say like 70. All right, let's just say 70 as a resting heart rate. As you were to, if you were to ablate the SA node, if you were to get rid of that tissue, you may go down to like say 50 to 60, and if you were just relying on the ventricle, you may only be like in the 40s or so. So you're getting progressively more bradycardic as you start to lose those. Yes, ma'am. It's a group of cells, so as you lose more of those myocardial cells, then you would potentially lose that effect. Yeah. So anyway, when we're looking at how these nerves are, how the parasympathetic nervous system is innervating those pacemaker cells, essentially what they're going to do is change how likely they are to depolarize, right? We talked about resting membrane potential being really important in setting how likely it is that an action potential will be able to trigger within a given cell. So for instance here we had the parasympathetic nerves through cranial nerve 10 is going to be releasing acetylcholine onto these muscarinic receptors, M2 being some of the primary ones there. So when you affect that, that's actually going to allow for release of potassium outside of the cell. So you actually open up these potassium channels, and we said potassium is in a higher concentration inside the cells, right? Right, we're salt-wrapped banana, most of our cells. So when you open up those potassium channels, you allow potassium to flow out. It's going to mean there's more positive on the outside, more negative on the inside. That actually lowers your resting membrane potential from, say, something like negative 55 to 60 millivolts down to, say, negative 65 to 75. That means you're less likely to have a actual signal happen, an action potential be initiated, which means that your heart rate would go up or down. Should go down, right? So when you have people have too much acetylcholine or too much vagal effect on the heart, it causes bradycardia, absolutely. So if you think about someone who has like vasovagal syncope, or someone who like strains too hard when they poop and they pass out, like a lot of that has related back to blood flow. You notice their heart rate would go down. There's a good episode of Scrubs where that happens. Basically, that's making it more difficult for the action potential to actually occur there. On the flip side, though, you can have the sympathetic nervous system where things like epinephrine and norepi, that's actually going to speed up heart rate, right? So think about your fight or flight system. You need more blood flow, more tissue, oxygen delivery. You need the heart to be beating faster. And this can primarily be occurring through these beta-1 receptors predominantly. So think about beta-1 effects on the heart being predominantly there. There's a little bit of beta-2 effect, but mostly beta-1. And what this can do is not only does it increase the actual speed of the heart, the actual contraction rate through the SA and the AV node, but this also can help the ventricles to contract harder. So it's a positive inotrope, and we'll talk about some of these different effects. But things that change the speed of the heart are going to be the chronotropy, right? So chrono, time, that makes sense, speeding up or slowing down the heart. But inotropy is going to be that contraction, the actual squeeze of the heart itself. You'll find the parasympathetic nervous system has the main effect on the chronotropy. You'll find the sympathetic nervous system does that, and also the inotropy is going to be the positive thing there. So again, it's going to do this by actually opening up and allowing sodium and calcium to inflow to the cells more easily, right? So now that I have more positives flowing into the cell, what does that do to my resting membrane potential? It raises it or lowers it? Should raise it, right? So now my resting membrane potential is more positive, which means it's easier for an action potential to happen. Okay, we'll look at the sodium flow and all the different electrolytes in the cardiac cycle in just a second. But just know that when you're adding more positives into this inside of the cell, you're raising that resting membrane potential. It's easier to have an action potential. Okay.
So is that where the beta blockers work?
Mm-hmm. That's exactly where the beta blockers work. Yep. And actually working through a G protein, if you guys remember that from pharmacodynamics. Yeah, working through cyclic AMP, and that can change sodium channel inflow, affect that calcium. We'll see calcium is really, really important for causing the actual contraction of the myocardial muscle. So we'll look at that more in just a few minutes. Everyone still with me? All right. At least one person is. That's good. All right, so again, looking at cardiac output, right? So this is going to be the actual blood flow coming out of the heart. This is usually measured in liters per minute. And here on this x-axis, we're looking at right atrial pressure, right? So this is in millimeters of mercury. A lot of pressures measured in. So again, when you have maximum sympathetic stimulation, notice here your cardiac output is going to be going up, because not only are you increasing the speed of the heart contractions, so how fast the heart's beating, but you're also increasing the amount of ventricular output because you're increasing that cardiac output. You're squeezing harder on those ventricles. Notice here if you were to have zero normal sympathetic stimulation, again, it would be kind of in the middle here. Cardiac output's going to drop pretty significantly. If you were to have parasympathetic stimulation, this is through acetylcholine, those muscarinic receptors, it's going to slow down the heart. It's going to lead to not beating as fast, thus your cardiac output goes down over time, right? So you're constantly in kind of a state where, right now you're probably having, minimal sympathetic effect, maybe a little bit of mild vagal effect. But if I were to, throw a bear in the room, obviously you have a lot of sympathetic effect, a lot of catecholamines flowing, that would end up leading you to have higher cardiac output. I promise I won't do that to you guys. It went well. Went bad for the last class. I tried that too. Okay. So looking at this electrical activity, so once stimulation is applied, you're going to find that the impulse is going to flow from cell to cell. Remember those intercalated discs that we mentioned? Right, that allows for a good flow of those action potentials from one cell to the next, and allows for that kind of functional sensation where the heart's basically working kind of as one strong unit together. Right, it's not going to have random cells all contracting at different times, because that leads to what? An arrhythmia, right? So arrhythmia is going to be from these kind of aberrant electrical potentials that are happening in different parts of the heart, and we'll look at why that happens in a few minutes. Basically, these intercalated discs allow for that flow of action potential, allow for those flow of ions to allow for the heart to work together as one unit. So again, the area of the heart that's going to be contracting from one stimulation event, as we're calling this the myocardium. You'll notice that the atria and the ventricles, as I mentioned before, get separated by that fibrous tissue. So basically, you're going to have the AV node right here, and you're going to have the rest of the bundle branches protruding through here. No electrical signal is going to be kind of processing through here. Right? It's only going to be going through these fibers right here. So the fibrous tissue is really, really important. Now, what would happen if you had, say, some tissue down here that connected back up to the atria? Yeah, that could lead to some problems. So have you ever heard of Wolff-Parkinson-White? That's what that condition is. So basically you have a piece of tissue that is able to connect from the ventricles to the atria that's not fibrous, and they're allowed for arrhythmias to actually occur there. So that can be a problem with some patients. Usually they end up having to get that tissue ablated, or basically use, I guess we use like cauterization to basically destroy that tissue and allow for a natural flow to occur again. Okay, so looking at the SA node, again, this is our pacemaker. It's going to be located in that right atrium, usually about 60 to 100 beats per minute. So again, kind of resting normal heartbeats there. You notice the AV node and Purkinje fibers are going to be secondary pacemakers, and these can be these are ectopic pacemakers. They're not really happening in those pacemaker cells naturally. But again, this is going to be slower rate than the sinus rhythm, say between 40 and 60. If you just had the ventricular pacer cells, that would only be about 20 to 40 beats per minute, right? So that's usually not sufficient for most people. Imagine you feel pretty crummy if you only had your heart beating 20 beats a minute. So we need to make sure we have those pacemaker cells there to make sure we have good stimulation of that. So you can notice how the flow of electricity is going to come from the SA node down to the AV node, going to cross that kind of fibrous tissue gap, bridge there, go down through the bundle branches, and then get spread out through the Purkinje fibers through the ventricles. Right, that's going to allow for that good flow of electricity, good contraction to happen there. One thing to note when we're looking at the resting membrane potential, so you notice here millivolts on the y-axis here, and then time over here on the x-axis. You'll notice that the SA nodes, or the pacemaker cells, they're going to function a little differently than your other myocytes, right? Because the regular myocytes, you don't want them to fire off on their own, right? You only want them to fire off when they have an action potential signaling that, right? The pacemaker cells, we need them to fire on their own because they're the ones actually setting the pace of the heart. So you notice that if you're looking at the membrane potential of these over time, you notice here that the ventricle, it kind of sits down here at this kind of baseline. It's pretty electronegative for the most part, and it does not fire off until it has a signal from one of those pacemaker cells, right? So again, these, if he gave no electrical stimulation, you'd find there would be no contraction whatsoever. So again, this is why if you had like a person who's dead, you could still apply electricity and still cause the contraction of the heart because those muscles are still, the tissue is still responding to that. Maybe not like super long dead, but maybe someone just died, right? They still couldn't respond to that. On the other hand, if you're looking at your pacemaker cells, you notice here how they kind of have this gradual slope up in their resting membrane potential, right? So they're leaky. They're gonna see that they have leaky sodium channels, and by having that, by having kind of a natural leak of sodium into the cells, you're gonna notice that it raises the resting membrane potential to a threshold, and that's what causes that discharge, right? And as they get reset, they're gonna cause that slow leak to happen, and then it causes a discharge. Slow leak and discharge. Like the other myocytes, if they're not a pacemaker cell, they should have no activity on their own unless stimulated by one of these pacemaker cells. Okay. So it's one of the big difference there. There's going to be no slow influx of sodium here. There's going to be no real flow of ions until it gets an action potential signaling it to happen. Okay, so again, the SA node and the AV node stimulate the atrial contraction. AV node, and then at the base of the right atrium is going to have that bundle of His. That's the bundle of His right here. And it's going to cause that, conduct that stimulation for the ventricles. And again, we want to cause squeeze from the apex up through the base of the heart to make sure we're flowing, causing the blood to flow appropriately through those semilunar valves. Again, the bundle of His is going to break down into the right and left bundle branches. So you can notice that here. So you have the right bundle branch, you have the left bundle branch, and notice depending on where things like cardiac ischemia happens, you can have blocks of this tissue. So you can actually have things like a left bundle branch block or right bundle branch block that occurs either due to medications or it could cause due to myocardial ischemia, things like that. And so that would mean that your ventricles may not be contracting at the same rate as one another. So you may have the one be a little bit slower than the other, which could eventually lead to arrhythmias occurring there. So just keep that in mind. Again, this is the general flow. Notice how the flow of electricity is kind of going in this direction. That'll be important. We're looking at the EKG, seeing how that's going, especially when we're looking at different leads and how that gets interpreted. Okay. Again, just notice that the SA node is going to be, when it causes a depolarization, all of the atria is going to contract together, right? Because that's when we're causing that the atrial contraction to occur. But it's not going to signal the ventricles. It has to go through the AV node, through the bundle branches before that can actually occur. And if that fibrous tissue wasn't there to cut that off, they would just all contract together. So that depolarization would be a very strong signal. So we need that fibrous tissue to separate them out. Okay. So looking at the actual action potential of the cardiac cells, the myocytes, normally you'll find that most, and again, these are non-pacemaker cells, they're going to have a pretty low resting membrane potential, about negative 90 millivolts. Okay, and we're going to talk about these depolarization as different phases. So usually resting membrane potential is going to be phase 4. So if the heart was not beating at all, you'd be at phase 4, right? Resting membrane potential. And having a signal coming from one of the pacemaker cells will trigger depolarization of the atria, especially from the atrial potential from the SA node causes depolarization of the atria, and the action potential from the AV node causes depolarization of the ventricles. Okay, so the SA node causes depolarization of the atria. Action potential here from the SA node causes the ventricles. So that's a signal that happens to cause those to contract. So we'll talk about the different ion flows that occur here, but you can see normally at resting membrane potential, once it has that signal from a pacemaker cell, you're going to cause an action potential to happen here, and then eventually get back down to baseline. Okay, in much more detail what's happening with that in just a minute. Okay, so we mentioned phase 4. You guys are going to love this, I'm sure, but you need to know all of this because it's very important, especially when we're looking at medications, especially when we're looking at different things that can affect how these cells are going to be conducting electricity. So essentially, what you can see here is that normally phase 4 is our resting membrane potential. Notice that we should be maintaining more sodium on the outside of the cell than we have on, and we have more potassium on the inside of the cell. Right, so that's our resting membrane. We notice how by things like the parasympathetic nervous system can affect potassium and change that resting membrane potential, but we like to keep K on the inside. And what maintains this balance? Yep. So sodium potassium ATPase pump is going to be the big thing that maintains that resting membrane potential. You should have at this point sodium and calcium channels being closed at phase 4. Should be nothing really going on at this point. There's also going to have these inward rectifier channels that are going to be open. So basically there's going to be a slow leak of potassium outside of the cell, going from inside to outside along its concentration gradient, but the sodium potassium ATPase pump is still going to allow for that same potential to be maintained essentially. Okay, so even though you have a little bit of outflow of potassium, the ATPase pump can still bring that back in. Okay. So again, this is considered a resting membrane potential. When you have phase 0, this is going to be depolarization. So some sort of pacemaker cell has signaled, hey, we need to have a depolarization happen here. And so basically what you find is phase 0. Notice how you have a very sharp increase in the electric potential here. The voltage goes up, usually above positive for a short period of time. You're going to notice that these fast sodium channels open. Sodium channels open. Sodium is going to flow along its concentration gradient into the cell. That's going to cause a sharp rise in voltage. Okay. You're also going to find that you're also going to have some fast potassium channels that are open here as well. You're going to have some outward flow of potassium here, but the sodium is going to be the primary mover here. Right? The potassium just kind of helps prevent it from getting too high of a potential there. So that's phase 0, so sodium channels come in. Then at phase 1, what you're going to have happen is the sodium channels close at the end of depolarization, and then you're going to have these calcium channels open. Okay, so sodium closes at phase 1, calcium channels open, and so this is why if you close sodium channels, you may have like a more of kind of a drastic decrease. But because we have calcium channels opening up, we have more positive flowing into the cell still. You're going to notice that there's going to be kind of a this dip and then kind of this plateau effect that occurs. Okay. And just to look at the sodium channels, what's happening here. So if you were to have, say, resting membrane potential, these sodium channels are closed. You have that action potential signal come along. It's going to open up these sodium channels. It's going to allow sodium to flow in, and then eventually it's going to inactivate itself. Okay, this is important when we're talking about refractory periods. This will come up in a few slides, and this is what's helping to prevent another action potential from coming along and triggering a cell to fire again. Right? Because again, we want this to be working in sync. and we don't want this to happen where these cells are going to fire off too early or too late in some cases. This is also important when we're talking about medications, because we can have certain drugs that actually block this effect, actually block these sodium channels, so that way you may not actually have as high of a peak here when that occurs. So we can see lots of medications when we get to pharm that'll be affecting these channels. Okay. So then in phase 2, this is called our plateau phase. This is where you're going to have these calcium channels are still open, and then you're going to start to have this closing of these fast potassium channels. So again, the fast potassium channels opened here on phase 0, but during phase 2, we're going to have them actually close up, and that's what leads to this kind of plateau effect here, right? Because now we have more positives flowing in, decay is staying inside the cell as well, so we're having that plateau happen. It's not getting back down to its resting membrane potential just yet. And then finally, you have your repolarization phase. This is where the calcium channels are going to close. You're going to have these slow potassium channels actually open up. You're going to have potassium flowing out of the cell, which leads it to get more negative. And then you're going to have the sodium-potassium ATPase pump actually start up now. This is where it's going to be shuttling sodium inside or outside of the cell. Shuttle out of the cell, and then potassium is going to come into the cell, right, against their concentration gradients, right, because that's an active process there. Everything else has been flowing along its concentration gradient until the sodium-potassium ATPase pump actually gets activated here, okay? So again, this is the repolarization phase. We're trying to get things back down to baseline, so that way we can have another contraction again. During phase 4, you can notice that the calcium, potassium, sodium channels are going to close. We're back down to resting membrane potential, okay? Make sense for everyone? Kind of go over it a few times, kind of know where in the different phases which ions are flowing in which direction. Okay. So again, just another picture kind of showing the same thing. Again, looking at milliseconds is a very fast process. Looking at the voltage here, you notice that the resting membrane potential, you have your sodium channels are going to open once they get the signal. Potassium channels are going to open here as well, and then sodium channels close. That's what leads them to not have an increase in voltage any higher. Calcium is going to open up. There's a lot of this plateau effect to occur. Then calcium closes, potassium opens, and now we get the repolarization. And then finally, you have the sodium-potassium ATPase pump maintaining that resting membrane potential. Everyone with me? Any questions so far? Okay. So we can have drugs that affect the potassium channel outflow here. We'll talk about things that can actually help to elongate this process, where it can actually lead to a longer repolarization phase that may help to prevent an arrhythmia. We can have certain drugs that can affect the sodium-potassium ATPase pump. We have drugs for everything, basically, where they can affect all these different channels to allow us to kind of modify this action potential to allow for prevention of arrhythmia or treatment of arrhythmia. You'll also find that a lot of those drugs, they can cause arrhythmia, which is kind of one of the unintended side effects of a lot of these. Because anytime you're monkeying with these channels, you can eventually lead to a potential arrhythmia. Okay. So that was how the action potential gets propagated and how it actually affects the cell. The other big thing to note is how the actual muscular contraction is occurring. And so this is going to be related to calcium influx. So you just have these T tubules that allow for calcium. When those channels open up, calcium is going to flow into the cell and actually trigger the sarcoplasmic reticulum. Once that gets affected, sarcoplasmic reticulum opens up. A lot of calcium flows out of the cell. This is what's going to cause the actin-myosin to contract together and lead to that actual contraction of the muscle. Okay. When the contraction is over, when you're starting to have that repolarization, notice there's going to be some ATP-dependent pumps here that are going to shuttle calcium back into the sarcoplasmic reticulum. Notice here you're also going to have that as you bring sodium, pumping sodium outside of the cell, you're going to have this co-transporter actually working a little bit faster to where it's sending calcium out and bringing sodium in. Okay. So for instance, we had a drug that blocked this pump here. So you guys heard of digoxin before? Right, so you sometimes use it for atrial fibrillation, sometimes for CHF. If I had a drug that blocked the sodium-potassium ATPase pump, what do you think that does to sodium concentrations within the cell? It should go up or down? Should go up, right? Because I'm not shuttling as much of it outside of the cells. Okay, now I have more sodium in the cell here. What do you think it does to this pump here? Make it work better or worse? Should worse, right? Because now I have too much sodium on the inside. This is not an energy-dependent pump. So again, things are not flowing along the concentration gradient as effectively. This means now I have more calcium in the cell. Okay, what do you think more calcium in the cell is going to do to my contractions? Make them stronger or weaker? Should be stronger, right? Because now I have more calcium in the cell. They can release more calcium out of the sarcoplasmic reticulum. So in that way, that's how we think that digoxin may work for CHF in some cases. By increasing the calcium levels inside the cell, notice how it's kind of a 2 or 3 step process there. You get stronger contractions out of that ventricular muscle, right? And that's one of the problems of the CHF patients is those muscles end up getting weakened over time. Okay, so just again, I'm not going to ask you specifically that on a test, but just know how these things can have an interplay with one another. And just because you're affecting one particular pump, could it be even though sodium-potassium ATPase pump has nothing to do with calcium itself, you can still affect calcium levels within that cell. Okay. All right. So again, the only difference, one of the main differences here with these pacemaker cells is that they're going to have these leaky sodium channels, and so you're going to find that they are going to have a constantly rising membrane potential, and once they get to a certain threshold, that's what's going to trigger the action potential to occur here. So if you were looking at, say, the SA node, you notice here how it has that kind of slow leak that causes its own action potential to discharge, which will trigger all the atrium. Okay. The AV node also is going to have its own slow leak sodium channels here, but notice how the signal is coming from the SA node much more quickly than the AV node. So because it's happening more quickly, it's going to trigger that AV node, and so you don't really need it to have its pacemaker function at that point. So basically, SA node overrides the AV node in most cases to lead to an action potential. Once that occurs, then you're going to have your ventricular myocytes are going to contract at that point, and this is where you're getting your basic QRS wave when you see that depolarization actually happen there, right? The ventricular depolarization. We'll cover the EKG in just a few minutes, but basically you see how this kind of all lines up with what the EKG strip actually looks like. Make sense? Okay. We're also going to talk about refractory period. So what do you think a refractory period is? All right, so it's a period of time where you cannot trigger another action potential, and this is good. And why is it good for us? Right, so if I'm at the end of a contraction of the ventricles, do I want something to come and trigger it before I've even had diastole? No, you need to have time for the ventricles to relax, to fill up again before it can pump out again. So if you were to have, say, something like ventricular fibrillation or ventricular tachycardia, basically what you're seeing there is that the ventricles are contracting too quickly, or they may be just kind of quivering there, and because of that, they're not able to fill well, and they're not able to pump blood out of the ventricles very well. So we want that refractory period. It's very, very important that we have that refractory period to prevent these arrhythmias from developing. And so essentially when you're looking at the normal action potential here, the point where no signal, no matter how strong, can trigger another action potential is called the absolute refractory period. Okay, so this ARP right here, it's not just for old people. This is going to be preventing any other contractions from occurring during this time frame. No action potential, no signal, no matter how strong, can affect it at this point. Okay. As you start to have repolarization, now you get to a point called the RRP, or the relative refractory periods. What do you think that means in conjunction, as opposed to the absolute refractory period? Yeah, so you need a stronger than normal signal to come along to cause that action potential to happen. But as long as you have a strong enough signal, you can still trigger it. Okay, it's not normal for an action potential to occur in this period, but when you have something like an arrhythmia or something like an ectopic pacemaker or a group of cells that are starting to act like a pacemaker when they shouldn't, that's when you can run into problems with this relative refractory period. That's what can lead to arrhythmia. So again, no signal can affect the absolute refractory period, but a strong enough one can do the relative refractory period. Okay, and then after that point, you're just back at baseline and you're ready for another action potential to come along. Okay. So again, if you were to have something like if we were to block, say, potassium channels at this point, what do you think it would do to the action potential? How do you think it would look differently? Yeah, plateau would be shorter or longer? Because you block potassium channels, you have more positive on the inside of the cell. It should be longer, right? So you can actually extend this repolarization phase. So we can do that with some of our medications. We can actually do that, prevent arrhythmias, by extending this absolute refractory period. By making that longer, it makes it more difficult for those either ectopic pacemakers or those range-turn arrhythmias actually cause a problem there. So that can be one thing we can do to modify the action potentials to prevent arrhythmia from occurring in that case, or to treat the arrhythmia if it's already happening. Does that make sense? Okay. So lots of things we can do to try to modify its action potential to the benefit of our patient. Any questions from the first half? So key things, you should be able to know what's happening during the cardiac cycle. You should be able to understand when I have ventricular systole, like what the valves are doing. You should know how the pressure is kind of changing between the atria and the ventricle. Obviously you don't need to know numbers, but just conceptually what kind of changes are happening there. Also knowing kind of during the action potential, what ions are flowing where, right? So know the big ticket ones like phase 0 is sodium inflow, right? Sodium inflow, right? And then we have sodium channels closed, and then we have calcium coming into the cell, right? So remember the concentration gradient. So everything's kind of flowing along this concentration gradient until you get to sodium potassium ATPase pump, right? That's the thing that's going to be helping to reset that resting membrane potential. Calcium's kind of an odd one because calcium being sequestered in that sarcoplasmic reticulum, being kind of held away in the cell, allows that calcium to flow into the cell appropriately. This is probably all kind of lifestyle, like it would probably not flow that direction, but that's important that we have those kind of recycling methods in order to allow that calcium to get back into the sarcoplasmic reticulum. Okay. So how can we monitor this? Like, how can we actually see if a patient is conducting electricity appropriately within the heart? Well, we use the EKG, the electrocardiogram, to check that out. So again, you probably have seen plenty of these on TV or in person. The TV ones, I always think like, man, this is so fake. Like, if I can see it's fake, it's pretty bad. Like, you guys need to work on your medical advisors there. But anywho, this is just recording the electrical activity of the heart by picking up the movements and ions of the body tissues, right? And so as the voltage is changing on those membranes, we're able to pick that up in changes in voltage, and we can measure that outside of the body, okay? So again, it does not record the specific action potentials, but basically what results from the waves of depolarization and repolarization. So you can't see individual myocytes, but you can kind of see just in general how the ventricles are contracting, how the atria are contracting when you're looking at these changes as the action potentials occur. Again, does not actually record the muscular contraction or the relaxation. Only the electrical events are happening, right? So, for instance, I can have an EKG that looks relatively normal, but you can have other issues that are happening where maybe if you have decreased blood flow, say you had anemia or you had a massive amount of blood being lost out of the body, you can't really tell how that ventricle is contracting or what the cardiac output is. It only tells you really how the action potentials are flowing, how we can see this depolarization and repolarization, okay? So you can see this process here. So if you were looking at one ventricular myocyte as it contracts, you can see the depolarization effect and the repolarization. And you can see how it kind of gets picked up here on the EKG. So initially, and we'll go through this in more detail, but initially what you're seeing is when you have the SA node contracting, you have the SA node firing off an action potential, right? This should trigger all the atria to contract together as one unit. This is where you get your P wave, right? So P wave is going to be atrial depolarization initiated by the SA node, okay? So then it's going to travel down to the AV node, where you get the kind of the P to Q kind of interval there. And so you notice, like, we'll talk about repolarization of the atria in just a second, but you're not going to be actually able to see that on the EKG, and we'll talk about why. But basically, as you have the contraction of the atria occur, you're going to have that action potential travel down that bundle of his. You're going to have it go into the into the Purkinje fibers. You notice that QRS, this is where you get the ventricular depolarization occurring at this point, right? So the Q, R, and S wave that occurs there when you have ventricular depolarization. As that travels and spreads up through the ventricles, we're going to have this interval between the depolarization of the ventricles, and eventually you're going to have the repolarization of the ventricles. This is your T wave. So T wave is the repolarization of the ventricles, and then you go and just basically start over again. Okay. So again, P wave is going to be atrial depolarization. QRS is going to be ventricular depolarization. T wave is ventricular repolarization. So get your V's and your D's together. Make sure you know the difference between them. How come we don't see atrial repolarization? Yeah, so it's actually happening at the same time as the QRS wave is happening, and because this potential is so much higher, there's such a large amount of voltage happening in the ventricles compared to the atria, you don't really pick that up. Okay, so atrial repolarization you do not see on the EKG typically because of the fact that QRS is covering it up. All right, makes sense so far? Okay. And there's segments we'll actually measure. We can measure these segments to tell us, is the heart conducting appropriately? Is it conducting too slowly or too quickly? And we can measure things like the PR interval. That can tell us, like, okay, what's the rate of depolarization between the atria to the ventricles? Is that happening too quickly or too slowly? The QRS interval, this tells us how well the ventricular myocytes are spreading that depolarization wave. You can see aberrations that occur there. I'll talk about some examples of those a little bit later. And then finally, we have this QT interval. QT is very, very important for discussing how well the ventricles are repolarizing, and if that's happening, if this QT interval prolongs too much, we can run into some problems with our refractory periods. This I'll illustrate in a second. And then finally, your ST segments. This will become really important when you're looking at myocardial ischemia. You can see ST changes happening pretty frequently there. Again, you'll have a whole class on covering all of this. Professor Q has way more in-depth knowledge on EKGs than I do, but this is, again, just kind of the baseline to make sure you guys are all on the same page. All right, so you can see how the ventricular contraction, the depolarization here kind of lines up with the QRS wave, and that repolarization phase is going to match up with that T wave there. and the P wave is going to be this atrial depolarization, and that's happening at the same time that atria are contracting. Okay, make sense so far? Pretty straightforward. You guys probably knew all that. Okay, so again, going back and looking at the action potentials and looking at those refractory periods, we mentioned the absolute refractory period means that no matter how strong a signal is, you cannot trigger another action potential until those cells have repolarized, right? Then you have the relative refractory period where you could have something, a strong enough signal come along, whether it happens to be an ectopic pacemaker or cells that are acting as pacemakers when they really shouldn't, or if you have some kind of aberrant arrhythmia, this can lead to an early depolarization. And so you can see that if you're looking at, for instance, this action potential here, you notice this green line is going to be the mechanical response. Notice how you have the action potential occur. It causes the contraction of the ventricles. And notice you really don't want to have any other contractions happening at this point, which is good because it's squeezing. You don't really want that to get triggered again. But during this phase, before the ventricles have had a chance to relax and fill up with blood again, if you had a strong enough signal, this could come early, right? And so we call that a premature ventricular contraction when that happens. So you can kind of see that here where you're looking at you see the force of contraction in the ventricle, and you're looking at the actual contractions themselves. Here you notice when you have a contraction, the absolute refractory period is somewhere up here. Relative refractory period can kind of happen down at this point here, where you're almost back to baseline, but not quite yet. And what can happen is if you have an early premature contraction, that can lead to another contraction of the ventricles before you've actually had time for it to fill. So at that point, you're not having very good blood flow. You're not having a good filling of that, so you're not getting good circulation out to the rest of the body, which is problematic, right? And again, they occur either early or late. The important thing to know is that during that relative refractory period, a strong enough signal could trigger another ventricular contraction, okay, which may not be good for us. Okay, so we mentioned that the P wave is going to be atrial depolarization. The PR interval is going to be during that time frame as we're having atrial systole occurring. Right, so the depolarization happens, and then the atria are going to contract in response to that. The QRS complex is going to be that ventricular depolarization. The ST segment is really that plateau phase. Okay, this is where you've kind of finished up ventricular systole as complete, and then as you have that repolarization, that's where you get your T wave there. And the QT interval is kind of showing us that full depolarization, repolarization to see if that's being prolonged or shortened or whatever happens to be. This is really important for me from a pharmacy standpoint because there's many drugs that actually prolong the QT interval. Okay, a lot of it has to do with those potassium channels, and when you have prolonged QT, you increase your risk for having things like those premature contractions. You can see arrhythmias happen. You guys ever heard of torsades de pointes? That's a unique ventricular arrhythmia. If you look at Google pictures of it, it's kind of unique looking. But that can happen when you have some of these drugs that can prolong that QT interval and allow for an arrhythmia to actually happen there. So again, drugs can affect this. Myocardial ischemia can affect these different things. So you'll get into more examples of that when you get into pathophys and things like that.
So during the ventricular repolarization right before that, it looks like it's a baseline. So why does it have to repolarize when it's on its mid?
Where at?
Like right before the T wave, it's the line that.
That has to do with basically, I'm not going to cover this in this class, right? It's a little probably too much, but it has to do with the vectors of how the electricity is actually flowing, right? So you'll notice, that this is just, we say ventricular depolarization, right? But the way that the left and the right ventricle, they should be kind of depolarizing at the same time. Sometimes you can see separations in that, and that's kind of what you're seeing a little bit there. The S wave is a little bit of the right ventricle stopping some of that depolarization. Because again, there's a little bit of speed difference between the right and the left ventricle, and so when you notice or how those fibers conduct, because again the left ventricle is bigger or smaller than the right ventricle, or should be stronger. Left should be stronger, left should be bigger. So like you want to have a bigger force of contraction because you're trying to pump blood to the whole body versus just dealing with the venous system. So there's a little bit of change in how those fibers are actually sending the signal and speed a little bit. So you can see that little dip there, but that's not necessarily saying that you're below your resting membrane potential, right? So an EKG does not equilibrate back to what the resting membrane potential of those cells are. Okay, you're just looking for change in the voltage as you have those kind of waves of depolarization and repolarization occur. Okay. It's an important distinction to make, though. Like, this is not your resting membrane potential. You wouldn't see someone who has, like, say, hyperkalemia or hypokalemia. You wouldn't see this line change necessarily because, again, you're just looking at your kind of baseline. What's the electronegativity of the heart? As that depolarization occurs, you're seeing those changes there. That makes sense? Okay. So again, we well, oftentimes when you actually get an EKG strip, normally how many leads do we look at when you do like an actual EKG? Yeah, you'll hear 12 lead a lot. We'll talk about what those 12 leads are. But usually when you're looking at a 12 lead EKG, you oftentimes get these intervals that are reported out to you. And so you're going to look at things like the PR interval. You look at the QT interval. Those will get automatically calculated by the computer that does the actual EKG. And so in a lot of cases, that's good because anyone could look at it and say, okay, well, these numbers look good. The rhythm looks good. That's fine, but a lot of times you'll find that the computer's not perfect at calculating a lot of this stuff, especially if you have any kind of like variations what the EKG looks like. And so sometimes you still have to do it by hand. And so there's things like trying to measure the QT interval by hand. You'll actually get like a little pair of calipers out and kind of go from point to point, figure out how long it is, and then be able to try to figure out what the actual interval is. So you won't have to do that too often, but occasionally you will need to. We can just know the P waves is going to be the atrials causing that depolarization. P to R is we're going to have the atrial contraction. QRS is we're going to have this actual ventricular contraction and depolarization occurring. T wave is going to be that repolarization. You can actually use the R to R interval. That's going to be from ventricular depolarization to depolarization. You can actually use this to gather, even if for instance, if you were looking at an EKG, you can tell how fast the heart's actually going just by being able to measure that R to R interval. You don't necessarily need the machine to tell you what pace the heart is going at. You can actually measure it out based on these blocks. Basically, each group of these blocks is 0.2 seconds, and so if 5 of these altogether would end up being 1 second, right? So for instance, if you had an R to R interval that would happen to be from, say, this point here over to this point here, so 1, 2, 3, 4, 5, so right here, how fast would the heart be going? 60, right? So if it's 1 second, if you had to beat every second, it'd be going 60 beats per minute, right? Yeah, so you can actually measure that out. So I'm not going to get into that necessarily here, but just know that you can measure all these things out and actually tell what the heart rate's doing. You can tell lots of information from that. Okay, so how do we actually see these? We're looking at different leads, and so this is giving us different pictures on what the heart's actually doing. And so I posted a video on the website. I don't know if anyone get a chance to watch that yet. It's a really good introduction. It's about 40 minutes long, so you guys are like, yeah, great, we got another 40-minute video to watch. It's really, really good, though. It talks about EKGs, talks about the 12 leads and why they are the way they are, what they're actually looking at. So I'm going to kind of go over a kind of a baseline analysis here, but that guy goes into a little bit more detail, and it's actually a really, really good introduction. Basically, though, the standard leads that we can have, and these are going to be called bipolar leads, you're going to find that you can hook up a lead to the right arm, the left arm, and the left leg. And so by examining how electricity flows through these different directions, you're able to get different views of the heart, essentially, to see how the ventricles are contracting versus how from different angles, essentially, right? And so why would it be important to look at the heart at different angles? Yeah, so you can see if there's aberrations in different areas of the heart. So maybe the anterior portion of the heart has suffered an MI. There's ischemia happening there. That tissue is damaged, and now it's conducting electricity at a different speed than it would be in other healthy tissue, right? So you want to be able to look at these different views in order to make sure that everything, the whole muscle itself, is working appropriately. And so we can do that by looking at some of these different leads. And so these first 3 we'll talk about are going to be our bipolar leads, because you're going to notice here they're going to have a negative end attached to a positive end. And so essentially, and what the guy did the video did a good thing. He said, think about when you're looking at these different EKGs, think about where the camera is focused at, right? So for instance, in this case, you always want to have the camera on the positive end of the lead. So in this case, you have negative here on the right arm, you have positive on the left arm, positive on the left leg. And so in this case, if I wanted to check out, let's say I want to look at lead 2. So I'm looking at the picture from the right arm down to the left leg. Imagine the camera is kind of focused here and looking up at this direction. Okay. Now I can tell how the heart is conducting electricity through this direction, right? Which is how the heart normally kind of lies. Okay. So normally when you see like a EKG like on a monitor, you're normally looking at lead 2 for the most part, because it's kind of the natural way to look at that. On the other hand, you can look from, say, the left arm. The positive end can be here. You're looking this direction. This is going to be lead 1. And just giving you a little bit different picture of the heart to see things a little differently. And we'll show you kind of what those different leads are going to be looking at. And then you can also have the left arm to the left leg, where basically your left arm would be the negative. You can have the left leg here looking this direction. That's going to be your lead 3. So it's important to know which leads correspond to which limbs at that point. Okay, so know that like lead 2 is going to be from the right arm to the left leg. Know that lead 1 is going to be left arm to the right arm. Know that lead 3 is going to be left leg to the left arm. Okay, those are good things to know. And then, so those are the bipolar limb leads. We'll also talk about the unipolar limb leads in a second here, but this is where you're going to get your 12-lead EKG, and this is where you're going to get be able to look at the heart in a lot of different directions in just a second. I'll show you guys that. So you can kind of see here, if you were to look at these voltmeters, if you're able to put them between these two areas, you can see how, notice how these three pictures are different, right? Because you're looking at three different angles of the heart and how they're conducting that electricity a little bit differently. And so I'm not going to get into the vector analysis and all of that on how that works, but just know that the picture is going to be a little different depending on which leads you're actually looking at. The positive electrode is going to be the camera. You're always looking from positive to negative. So if I'm looking at lead 2, which again, lead 2 is going to be which limb to which limb? Right arm to left leg, right? So it's going to be lead 2. So I'm looking from the right arm down to the left leg. You're going to be noticing you see lead 2 right here. You're basically looking at that electric depolarization coming towards that direction. So you can see as it the cells go from net negative because they're at that resting membrane potential, which is negative. You can see that depolarization as they get more positive and kind of repolarize as you go along. Okay, so just know you're looking at different angles to be able to see how the heart's conducting that electricity. The bipolar leads, though, we call them that because sometimes they're really happy and then sometimes really sad. Just kidding, we don't. We call it because they have two opposite physical poles. So we notice here we had the positive lead on the left arm, on the left leg, and then the negative is just going to be on the right arm there. Okay, that's why I call them bipolar, because they have two different leads. Okay, so I mentioned here lead 1 is going to be between the right arm and the left arm, lead 2 between right arm and left leg, and then finally lead 3 between the left arm and the left leg. And again, just showing a few different directions of how you can look at that electricity, how it's flowing. You can look at different, see if damage is occurring at one site versus another. Okay, you also have your unipolar leads, and so these are called your precordial leads as well. And so essentially when you do a 12-lead EKG, this is kind of what you're going to be looking at. Basically what the computer is doing when it's measuring this is it, instead of having a negative lead on, say, like your right arm, what it's going to do is it will use math. Math is hard, but this machine's pretty good at it. It'll put that negative right in the middle of the heart. Okay, so basically you're always measuring out from the heart out to that lead, whatever it happens to be. So I'll show you a picture of what that looks like a CT in just a second. But by using these different leads here, you can actually measure how the electricity is flowing on different sides of the heart. So we'll look at how that is, but you basically get these other leads. So you have your V1, V2, V3 through 6. Those are all going to be noticed right here. Basically that's flowing from the center of the heart out to wherever that limb lead is, or wherever this precordial lead is. Okay, so middle of the heart out to the 1, or out to 2, or out to 6. For these other ones, the AVR, this is actually going to be measuring from the center of the heart looking over to the right arm. Okay, you notice how this is actually going to look a little different. Notice how it's kind of backwards to what like the AVL and the AVF look like. Again, because you're looking at electricity flowing from a different direction. But AVL is going to be over to the left arm. So again, center of the heart over to the left arm, so you're kind of looking from that direction, and then AVF is going to be from the foot, so you can see it from that direction. Okay. Again, we'll show you more detail in just a second. Those are called your unipolar limb leads, and based on measuring that voltage from the center of the heart, where again the computer is kind of calculating what that negative should be right there in the middle of the heart, out to wherever the leads are actually going. Unipolar limb leads, again, you go to the right arm, left arm, or the left leg, so to kind of know what those are referring to. If I were to ask you on a test, like which lead measures from the heart over to the right arm, you'd say, hey, that's AVR, or from the heart to the foot, you say, hey, that's AVF. Okay. And so also you have the hexaxial leads. Those are going to be the 6 leads you're going to actually put around the heart itself. So those are the ones that go on the chest and the trunk. And again, based on this direction of the electricity that occurs, you'll see that there's different angles that it can go to. And again, I'm not going to get too much into this on this class, but this is why you're going to find that the QRS waves will peak at different levels based on the way the direction of the electricity is actually heading there. Okay. All right. So notice there's going to be 6 unipolar chest leads. Again, these are the precordial leads. Notice how you're going to be placing these around. And again, if you were to have, we mentioned which side of the heart's working harder most of the time. The left side, right? So oxygen demand for the left side should be higher or lower than the right side. Should be higher, right? You need more oxygen in order to make that muscle contract to allow for that blood to flow. So if you're going to have ischemia of the heart, where do you think it's going to be hitting it first? On the left side, yeah. So typically if you're looking for like an MI or something, you can actually use these leads to be able to look at the direction of electricity from the center of the heart out to these different areas. And this can tell you, do you have an anterior infarct? Do you have lateral infarct? Whatever it happens to be. It can give you a better idea of which specific coronary vessels might be affected by this, and that can tell you where the MI actually is, the infarction is actually occurring. So does it really tell you a whole lot about the right side of the heart? Not really. You can do right-sided EKGs. I've seen that done occasionally. That's usually for patients who have issues with the right ventricle. Usually if they have like pulmonary hypertension, there's a lot of pressure in the lungs, and that is actually impeding flow out of the right ventricle. Sometimes they'll measure it for them as well because they can have some issues that happen there. But the majority of the time, you're going to notice that these precordial leads are going to go around the left side of the chest. Okay. So you can notice here, just kind of illustrating where the leads are going to be heading to. If you have your bipolar limb leads, and again, notice how many leads we have now? Yes, 3, 3, and 6. We've got 12 leads. That's it. That's our 12-lead EKG. We have them all now. It's like Pokemon. We've collected them all. Sure. Okay, so again, bipolar limb leads. Again, those are using it. We're not using the heart as the center, as our negative, right? We're still using the limbs to use that. So again, from limb 1, right arm and left arm. Lead 2, right arm to left leg. Lead 3 is going to be left arm to left leg. And basically you can see how that works. If you're looking at lead 2, for instance, you're going from the right arm to the left leg, and so you can see how the direction is heading through the heart itself, right? Versus the lead 3, if you're doing left arm to left leg, you know, so it's going to be measuring it from a different angle, getting a little bit different readings there from that electrical discharge. Now, so your limb leads, your precordial leads are going to be going around that left side of the chest. I'm not going to go over placement. You'll have a whole class just on that too to show you how you should place those actual leads. Okay, so looking at a standard 12-lead EKG, so you can see here how the different leads are going to be represented. So usually 1, 2, and 3. You have your AVR, AVL, and AVF, which we know that these are going to be unipolar or bipolar. Those are unipolar, right? And then we have our precordial leads of V1 through V6 are going to be listed here. And then normally you're going to have a rhythm strip where you're going to have lead 2 that's being there at the bottom. So one of the things I did not actually realize this until I was studying up on it was that when you were looking at these, when you're looking at lead 2 across this whole spectrum here, notice that the machine is only measuring lead 1, 2, and 3 at this point, and this point. Okay? That does not mean that this beat here with AVR correlates to this beat here. There's no correlation. These are different heartbeats that are actually occurring here. You can measure, you can line them up vertically, but not from lead to lead. Okay, so that's one important thing to kind of note, because if you were to have like an aberration, say like V5 looked funky because there was a PVC that happened there, you can't really use that to correlate back to any of the other leads. So just be aware of that. But in general, you're going to notice that lead 2 will be there on the bottom to kind of give you an idea over time how the heart's actually beating. Okay, if you notice any PVCs or if you notice any other arrhythmias that are actually happening there. So based on the placement of the leads, you can see different aspects of the heart. And so this is where we're kind of referring to this. So if you're looking for the inferior aspects of the heart, so where you can use lead 2, lead 3, and AVF. And that makes sense because we mentioned from these 3 leads, where's the camera positioned at on the body? On the foot, right? On the left foot. So when you're looking from the foot up to the heart, you can see kind of the inferior aspects of it. You can kind of see what's going on in the ventricles there. Okay, that makes sense. You can look at the high lateral. So this is usually going to be, there's going to be some overlap, and I'll show you a picture in a second, but there's some overlap between the different precordial leads. But essentially you can notice high lateral with lead 1, which makes sense because lead 1 is going from which limb to which limb? Right arm and left arm, right? So you're kind of looking from the left arm over to the right arm, and so high lateral is going to be, you can focus on that part of the heart. AVL is also going to look at that as well. And again, AVL is looking at the from the left arm to the center of the heart. That makes sense. AVR is kind of the oddball. AVR is actually looking from the center of the heart up to the right arm, so that's why it looks opposite, because you notice how most of the QRS waves go in the positive direction. AVR actually goes in the negative direction because it's actually measuring it from a different, the opposite angle than you do everything else. Okay. But we actually look at AVR pretty frequently because this actually helps us to, when someone overdoses like on certain drugs, we can find changes here that actually give us an idea if we need to treat that person or not with a particular antidote. But besides that, you can also have some septal leads. So septal just looking specifically at the septum of the heart, right? So notice if there's any damage there. So this is like your V1, your V2, and that makes sense because notice where V1 and V2 reside, right? So right sitting there over the septum of the heart. Then you're looking at your anterior aspect of usually the left ventricle, so you can notice V2, V3, and V4 are going to be looking at that. And then finally lateral, V5 and V6 are the main things that look. So you notice how it kind of goes more towards the armpit. That's going to be looking at that lateral side of the left heart. Make sense so far? Clear as mud? Probably. Okay. So just be aware. Again, know where the leads are actually heading. So if I were to say, you know, AVL versus lead 2, like know where those leads are actually going. I'm not going to actually test you to see like, okay, V1 is either septal, high lateral. Like you'll have other classes and you'll learn that stuff over time. So I'm probably not going to get that granular with it. But at least once you guys know the concepts, know where these leads are actually coming from and why that makes sense. So another picture just kind of showing you which aspects of the heart that the different leads are going to be looking at. So again, very similar to what we saw in the last slide there. And again, if you were looking at a CT of the person, right, so this would be the back of the person, here's the vertebrae, here's the heart here, you can notice where the different leads are going to be looking at. So again, V1, V2 being right there on the front of the chest, looking at the septum, looking at the anterior leads, your lateral precordial leads. Notice there's a little bit of overlap between some of these, right? So you can notice that V2 you should see anterior as well as the septal effects. And so it's important because if you're looking for changes like in your ST segments, you're going to be able to locate where specifically on the heart that's happening based on where the changes are occurring. So you know if you have changes in V5 and V6, that's probably a lateral MI versus if it were to happen more of like an anterior MI in like V3. Okay, so again, just know that they're looking at different angles to be able to identify where those changes are actually occurring there. Okay, so if we're looking at our heart sounds along with the EKG, we can kind of see where these are falling into place. So again, the lub is going to be what sound? S1, it's the, which valve's closing? AV valves closing, absolutely. So again, that's going to be happening just prior to systole. So you notice your lub's going to happen here. There's arterial pressure, how that's changing. It's going to be right after that depolarization of the ventricles occurs. You're going to have that contraction there. And also your dub is going to be during the diastole of the ventricles. That's going to be which valves closing? Yeah, semilunar, so your aortic and your pulmonic valves are going to be closing there. And then you can see where that's occurring during that diastole period. Again, we were looking at the pressure. This is similar to that big graph we were looking at before, how the pressures are going to line up here. Again, notice once you have that systole that occurs there, you're going to have that contraction. Again, this is that short period, that's that kind of isovolumic contraction that happens there. And then as you overcome that pressure in the ventricle into the semilunar valve, that's where you're going to have that blood being expelled there. There's how the EKG, the QRS wave is going to be that depolarization of the ventricles. It's going to lead to that contraction, lead to that increase in pressure, and that's where your S1 is going to happen there. And then you have the repolarization. As you have diastole occur, that's where T wave happens. Okay. Okay, so some things you can look at. The heart arrhythmia is detected by EKG. Certainly you can look for lots of different abnormal types of arrhythmias. You can have things like bradycardia, which bradycardia is just slow heart rate, usually below. Yeah, it's usually below 60. So below 60, and again, is everyone who has a heart rate less than 60 sick? No, I mean a lot of healthy athletes, can be in the high 40s, low 50s, no problem. Tachycardia, usually fast heart rate. You mentioned usually over 100 we would consider to be tachycardic. And notice how these are different, right? Notice how the heart rate has changed. Both of them are a regular rhythm, which just means that you're still having a regular rhythm of contraction between the atria and the ventricles. Other things you're going to be looking at are going to be like the PR intervals, the QRS intervals. You're all going to be looking at these things. And again, the speed of depolarization shouldn't necessarily change. Because again, when you have someone who's bradycardic, we mentioned that's due to the parasympathetic or sympathetic nervous system. Parasympathetic, right? Releasing what onto the muscarinic receptors? Acetylcholine, right? So that really only affected the SA and the AV node, right? So it affected potassium on those pacemaker cells, but it really shouldn't affect the ability for the ventricles to contract. It really didn't affect those cells at all. So notice here that even though one heart rate is less than 60, one's over 100, notice that the PR interval, the QRS interval, they're both about the same. Okay, not a big change here because the actual cells themselves are still depolarizing at the same speed. It's just a matter of what kind of influences are saying to those SA nodes and the AV nodes, like how fast should you be actually beating. That make sense? Okay. But if you were to have a problem where you're blocking potassium channels or something like that, you would see that QT interval start to increase, and that's where you can run into risk for those arrhythmias from developing due to like ventricular contractions and things like that. Okay, so I included this just as an example of how I can utilize from my tox standpoint, an example of where we look for EKG changes to indicate a patient may have been exposed to a drug. So you won't be tested on this, but one of the things we look at with tricyclic antidepressants, are you guys familiar with any of those drugs? Anyone know a name? Like amitriptyline, you ever heard of that, or Elavil? It's kind of the prototypical. Anyway, they're old school depression drugs, but they, oftentimes, when you have a depressed patient, like what do they oftentimes want to do? Kill themselves, right? They want to harm themselves. Now we give them a drug that's super dangerous. So I was like, oh, that seems like a good idea. But we didn't have anything better. So anyway, so this is a common drug for people to overdose on, and what we actually saw is that it was causing sodium channel blockade. So we said sodium channels, okay, they're involved with which phase of the action potential? Depolarization, right? So phase 0, right? So phase 0, that depolarization occurs when the sodium channels open up. Well, what would happen if I block some of those sodium channels? Would depolarization happen more quickly or more slowly? It happen more slowly, right? So that's one of the things we can look at. So you would expect the QRS interval, which is measuring that QRS, the ventricular depolarization, that should be slowed, right? Which means our QRS interval actually prolong out, and so that's one of the things we can look at. So if a person has a prolonged enough QRS in conjunction with this overdose, I know that, okay, they have a lot of their sodium channels being blocked. I know I need to fix this, and we can give an antidote. Basically, we give them, we do serum alkalization, try to alkalize the blood. But you also can have like tachycardia due to the muscarinic receptor blockade. So these drugs also sit on the muscarinic receptors and prevent acetylcholine from affecting them. So now you're kind of blocking that parasympathetic effect, and that causes heart rate to speed up, right? So not only is it speeding up the heart rate, it's also slowing down how the ventricles are contracting. So now you can see how this is kind of a recipe for arrhythmias to pop up, right? So it can be a very, very dangerous drug to overdose on. Lots of people have died from it before. But basically we can look at things like, look at this prolonged S wave in lead 1, and we have this thing we call an R wave in lead AVR. And so that can be a sign of sodium channel blockade, and that's what we can look for from the toxicology standpoint. I can look at that and be like, okay, well, this looks like a person who was overdosed on some sort of sodium channel blocker. They're tachycardic, so if you were to measure this out, you'd actually get them being as tachycardic. And I see the sodium channel blockade. I know I need to treat them, otherwise they can go into ventricular arrhythmia and die. Okay, so just an example how we would use this in the real world, at least from a kind of a non-standard kind of EKG we would be looking at there. But again, notice you have all your bipolar leads, have your unipolar leads here, and then that rhythm lead 2 is going to be down along the bottom here. Any questions on that? Okay, so this would not be considered a normal EKG. So yeah. All right, that's it for me. Do you have any questions on anything we covered so far? You probably will have questions. That's okay. Either talk about next class, or if you have any questions, you can email me. Otherwise, I will see you guys on Monday.